She serves as the Medical Director of Pediatric Anesthesia at AMPLATS, where in addition to her clinical practice, her interests are in cardiac anesthesia and in ultrasound-guided paravertebral catheters for post-op pain relief. Dr. Clinton's educational route, as we say in Minnesota, was a little more circuitous, having completed her undergrad degree at the University of Iowa, go Hawks, medical school at the University of Minnesota, residency training at the University of North Carolina, and fellowship in pediatric anesthesia at the Children's Hospital of Boston and the Harvard Medical School. She oversees educational efforts with the trainees and has an interest in cardiac anesthesia and pain. They're going to speak on a topic that should be of interest and importance to all pediatricians, the impact of anesthesia on the developing brain. And please join me in welcoming them to our grand rounds.
Good morning. Can everybody hear me okay out there? Okay, just want to make sure. Well, thanks, Tom, for that nice introduction. It's a pleasure for us to be here today and certainly to share with you a topic that has become pretty near and dear to our hearts, certainly as pediatric anesthesia providers, but also just with the fact that this particular topic has been gaining really wild momentum in terms of media coverage, increased amounts of medical literature being produced about this topic, and like Tom said, I think it's something that all pediatric providers certainly need to be aware of, and that it's going to become our job in the future as pediatricians to answer parents' questions about this. If you take just a second to even Google at any point in time right now, anesthesia, baby risk, infant risk, child risk, learning disabilities, I mean, it's amazing how much you get back on that, and many of it is parents blogging about this sort of thing, so certainly there has been an increased attention to this problem. And I thought it'd be really relevant for trainees and other practitioners to hear about it and sort of together talk about, is there anything we could be doing to improve the care of our patient? And is this a real relevant risk? Or is it just something that's in the literature and there are some animal studies to support some neurologic devastation? The human studies are maybe at best suggestive at this point. But I'd like to pose the question at the end and hopefully generate some discussion with you all about what can or should we be doing differently. And I think both Megan and I feel strongly that there are things that we could do to improve the care of our patients at this point in time relative to this particular issue. So I'm going to move ahead and just show you a little clip in the news more recently. Unfortunately, we are having a little bit of technical difficulty, so I'm going to try and play the audio through the microphone. This was a clip that was generated from an ABC News website from 2011. And I'm going to go ahead and hit play here.
One thing that parents worry about when an infant needs an operation
Can you hear it at all?
Anesthesia to drugs that put a baby.
Okay. Let's.
Sleep have an effect on brain function.
Dr. J. Adelsberg is here with
Can you guys even hear it? I don't know why the Fairview guest keeps wanting to pop up to us, but do you want to fix that? I think I'm just going to move ahead. Basically, I just want to highlight the point on that video that, hold this. So this came out in 2011, which was a relevant time point because that's when the New England Journal of Medicine, obviously a very prestigious journal, published an article about defining the safe use of anesthesia in children. And I think it was really at that point, too, that practitioners that weren't necessarily immediately involved with the care of pediatric patients in the perioperative setting potentially started to hear a little bit more about it. And so it did receive increased and broadened attention. So before we move on, we need to disclose formally that we unfortunately have no financial disclosures to report. So we aren't making any extra money right now. And then talk to you a little bit about the objectives that we've outlined today prior to this talk to your group. So first and foremost, we want to cover with you some of the current concerns regarding anesthesia use and the associated neurotoxicity in the developing brain. We'll share with you and discuss some pertinent animal studies. We'll share some of the more frequently cited human studies as well, and then talk to you a little bit about what current research efforts are underway and what the FDA and other organizations are doing to try and tackle this problem. And then finally, we'd like to apply some of the information that we've shared with you and talk about how can we apply this to clinical decision making or a potential algorithm in the pediatric population. So specifically, I'm going to start this discussion and share with you a case scenario about a patient that I did take care of here in the pediatric sedation unit. We're going to talk a little bit more about why do we even care about this problem? What is the real concern about this? And what are the factors and the mechanisms of injury that we need to really consider? And then finally, what anesthetics are responsible for this? Is it all the anesthetics we use, or is it just a handful of them? And then, as I said, we'll talk a little bit about the animal and human data issues. We'll move on to some of the current research and the FDA statement that was just released actually in December of 2012, and talk about how we might mitigate some risk and conclusions we can draw, and then leave some time for hopefully some thought-provoking questions and discussion. So here's our patient, this sweet girl, Molly. She was an 8-month-old girl that I saw in the sedation unit, as I mentioned. She was an X32-week preemie. She arrived in the sedation unit on the morning, this particular morning, with both of her parents, and was there for a brain MRI. According to the parents, she had had some reduction or delayed milestone achievement, and her primary care provider outside the Fairview system had wanted to order this basically just to see, was what the parents said. They weren't entirely clear on what they were trying to learn from it, how it might alter the management. They told me that she was participating in physical therapy, she'd been eating and growing well, but there was just some underlying, mild diminishment in her achievements and a suspicion of CP. So the question I want to pose to you and like you to kind of think about as we move through this talk today is, should we be performing this MRI given the current clinical information that we have and the concerns about potential neurotoxicity issues and the potential for long-term cognitive dysfunction in young children like this Molly who might receive a general anesthetic? So again, what is the actual concern? Well, unfortunately for us, basically the majority of routinely used anesthetics that we use every single day in the operating room have been implicated in some fashion to causing neurotoxicity. I'll go over a more complete list in a second. You can breathe deeply and take a little breath of relaxation that the opioids, since we use those frequently, those are not ones that have been particularly shown. But basically everything else that acts in a GABA-mediated fashion or as an NMDA antagonist has been shown to be problematic from this standpoint. When you look at this problem as a whole, one important point to realize is if it proves to be a real issue, this is a very large problem, considering that we actually anesthetize 6 million children in the United States alone annually. And if you break that down even further, about 1.5 million of those are infants. So you can see if this proves to be anything, it could really have far-reaching effects and really could dramatically change the way we practice. So basically, like I said, we know that routinely used anesthetics have been shown to produce some neurologic devastation and behavioral changes in some animal models, primarily rats and mice. There are retrospective studies out there now that show or suggest some sort of association between anesthesia exposure and an increase in learning disabilities, neurocognitive dysfunction, behavioral disorders, etc. And we believe or we know that anesthetics administered during what we would call this sort of, quote, critical vulnerable period lead to an increase in neurologic devastation. And what does that mean exactly? Well, as you all know, when an infant is born, there is a process of peak synaptogenesis. In the normal development process, there's normal pruning going on. There's normal programmed cell death or apoptosis that goes on. But it's possible that when we expose these infants or young children to anesthetics, that we either blow this normal process out of control or this is an injury directly related to the drugs that we have given. At this point in time, if we look through the medical literature, there are various time points that are cited in terms of being the true vulnerable window for infants or children. And the majority quoted is somewhere between the end or middle of the third trimester to about the third year of life. So many, many, many questions remain, and we will never get to the bottom of this today and probably for many, many years. But certainly I think it's important to kind of ask ourselves these other questions that might be confounding variables to the study of this important problem. Is it just the anesthetic that we're giving the patient, or is it the fact that this patient is an underlying or already destined to not be completely normal from a neurologic standpoint? Those things we often don't know. Is it the operation or the surgical stimulus? Clearly, surgery in and of itself induces various humoral changes in the stress response, and that in and of itself may lead to some of these changes. Or is it a combination? It's probably a combination, but like I said, at this point, we really do not know. So as I alluded to at the beginning, I'm sorry that you were not able to hear that video clip, but certainly there's been an increasing media and FDA attention to this topic. And the top little area there shows the New England Journal of Medicine title that I mentioned earlier, Defining Safe Use in Anesthesia in Children. And this article was written by a group that basically was organized along with the FDA, a group of physicians, to essentially create a statement about the current situation, what we know with our background data, preclinical studies, and make a statement in terms of how this should alter clinical care. And in 2007, they basically said no changes are warranted at this point. There's nothing definitive out there. And then in 2011, they again reviewed this and essentially concluded the same thing, but recognizing that there's a lot of work that needs to be done in this area. And we'll move forward because I'd like to get talking to you a little bit about the mechanisms of injury and what we think are the potential factors at play with this problem. So, I mean, I really distilled this down to one slide, and obviously it's a hugely complex topic, but there are kind of a few main proposed mechanisms of injury when it comes to anesthetic-induced neurotoxicity. This schematic on the left-hand side highlights that probably the main mechanism that's talked about, in that the majority of drugs that we use, or this anesthetic cocktail, act on either NMDA antagonist sites and diminish the effects of glutamate, or the excitatory neurotransmitter in the brain, or they act on the GABA site where they increase inhibition via GABA receptors. So the anesthetic cocktail or alcohol actually acts on both of those, ultimately leads to a translocation of this protein Bax. And some of the detailed steps that are in between there have not entirely been worked out, but what ultimately ends up happening is a cascade effect with an increase in cytochrome C, and then ultimately activation of the caspase-3 enzyme system, which, when that becomes activated, is responsible for the extrinsic pathway of apoptosis in general. So that's kind of the main mechanism that's often studied in some of the animal studies, because frequently that caspase-3 enzyme is the one that is marked for in the studies that they do. And certainly this impact, as I already highlighted once, and we'll kind of come back to this point many times, that the greatest impact is thought to occur during peak synaptogenesis. The other mechanisms that are thought to be at play include things such as inhibition of neurogenesis, alteration of dendritic spine architecture, and then also some inhibition in important signaling pathways too. So clearly multiple mechanisms potentially are at play with this issue. What anesthetic drugs then are implicated? Well, as I mentioned, they come in mainly two classifications, and because not all of us have the same background at this point about some of these medications, I just want to briefly sort of highlight for you what we might use these drugs for and how we might use them, because it does in some ways become relevant when you look at some of the animal studies, because they use drugs in some of the animal studies that are not the way we use them in the operating room, which lends to some of the criticism of the studies at times. So, I mean, obviously we all use benzodiazepines in our practice for various things. Certainly in pediatric anesthesia, we use it mostly for anxiolysis at the prior to induction of anesthesia. Occasionally we will use it intermittently for sedation as well, but that's the primary purpose, I would say, in pediatrics. Propofol, obviously we use that for sedation purposes. We use it more commonly for induction, but also for some of our anesthetics, like this brain MRI I was just mentioning. Often a child like Molly, probably a little bit older, but we would have someone like that on an infusion of propofol for a period of time for her anesthetic. Etomidate, while we don't use it all that often in pediatrics, is used as mainly an induction agent. The barbiturate's much less commonly used now. And then obviously we use a lot of volatile inhaled gases in our practice. Most commonly the one that we use in pediatrics is sevoflurane because it's well tolerated by patients, but there are basically three at play in the United States today's day, which is isoflurane, sevoflurane, and desflurane. And many of the studies that I'll talk about, and also the data that's out there, primarily has focused on isoflurane. A little bit on sevoflurane has come out. Regarding the NMDA antagonist, so ketamine is one of the main ones that's been studied in terms of preclinical studies. Certainly ketamine is used occasionally as an analgesic. We often use it for difficult cardiac induction purposes as well. Other things to mention along that side are nitrous oxide, which is, I would say, coming out of use in pediatrics, but we still use it in the operating room when we like it, and then xenon, which is also a gas. So to look from a historical standpoint at sort of what preclinical work has been done, I think it's important to talk about probably one of the first main articles that came out that demonstrated this problem, and that was in Science in 1999. And basically this researcher, Kamadou and colleagues, did a study in developing rat brains or rat organisms where they exposed the organisms to a 3-hour anesthetic, so not that long, and found extensive apoptotic neurodegeneration in these brains. And really from that point, the next article I'm going to talk about is really, I think, more of a sentinel article. And literally from this point on, the amount of literature out there on this has absolutely exploded in terms of animal and preclinical studies. So this is a really important body of work that was actually done at the University of Virginia and WashU. And these investigators looked at 7-day-old rat pups, which, if you look at that as it correlates to potentially a human developmental standpoint, would roughly equate to maybe a 3 to 6 month old infant that's born term, or maybe a slightly older infant that was born in a preterm child. Now, what the investigators did, they basically took their two groups, they exposed them to a 6-hour anesthetic cocktail that was representative of what we would do in pediatric anesthesia. So they used isoflurane, nitrous oxide, and midazolam. And then they looked at the histopathologic changes, what are some of the behavioral changes that were seen in the juvenile and the adult rats, and then was there any long-term potentiation abnormalities noted. So that, in and of it, studying long-term potentiation is important for learning and memory formation, and often looked at in these studies as well. So what did they find? Well, interestingly, I think, they found that essentially with nitrous alone or midazolam alone, there was really no significant increase in apoptosis. Isoflurane, as has been demonstrated in multiple studies now, showed a very distinct dose-dependent apoptosis response. So I think that's something that's important that Megan and I will highlight at the end about what we might be able to do currently now to make things potentially better for our patients. And then finally, with this triple cocktail, which we use really all the time, they found a really robust response in terms of neuroapoptotic degeneration. They also noted profound burst suppression of the long-term potentiation, so learning, memory, function issues with the hippocampus, as well as long-term impairment in spatial learning and memory in the juvenile or adult animals. So from that standpoint, it suggests like there probably is a problem, and obviously there are potentially some functional outcomes that we need to be concerned about as well with exposure. I will say, and I'll highlight this again in a moment, but one of the sort of criticisms of a study like this is often much of this work that was done earlier was not in the face of some sort of applied surgical stimulus, and people often criticize that because they feel that possibly that the general anesthetic is actually neuroprotective in that setting. So that's an important piece to kind of try and separate, or at least to keep in the back of your mind. So moving forward, I attempted to count how many articles have really been out there since then, and literally there are probably at least 100 or more that have been written about in terms of all these studies in different animal models. We've been moving forward a little bit in terms of studying non-human primates because, in theory, they'll provide us a better look into the human mind or as a model. And this is a study that I just briefly wanted to share with you that talks about ketamine-induced neuroapoptosis in fetal and also neonatal rhesus macaque brains. And these researchers published this in Anesthesiology, I believe it was February of this last year. And basically, they took two different groups of monkeys. They took postnatal day 6 monkeys, which would correlate to about a 3-month-old infant, 3 to 4-month-old infant, and 120-day gestation pregnant females. So again, premature infant or essentially a fetal organism. And exposed them both to 5 hours of ketamine and determined that they had reached a surgical plane of anesthesia by the application of a surgical stimulus. So that's a positive thing about this study, I think. And then basically woke the animals up, anesthetized them again, and then euthanized them and looked at the results. So what did they find? Well, I think interestingly, or I mean really not that surprising, they did find that there was an increase in apoptosis in both animal models versus the controls. And they found that there was about 2 times greater loss in the neurons that were fetally exposed. So clearly suggesting that possibly fetal versus neonatal may be a more susceptible time. But obviously, all those various time points are not clearly worked out at this point, but it's definitely something to think about. The other important point that I like to highlight from this study that was interesting is when they looked at the patterns of destruction or devastation, I guess, from this, they were different for the two organisms, suggesting, again, that the fetal organisms may have a different pattern of susceptibility than the neonatal organisms. And that may translate to different functional outcomes, which, if you apply that then to humans, you can imagine that there could be lots of different manifestations of this. So how exactly do you really, really study this really well? Because you don't know what the primary functional outcome or deficiency will be. So obviously, all these things make it a very challenging topic to study. So I just want to conclude and turn things over to Megan here about what really then have we learned from these animal studies. Well, I think it's pretty clear that certainly these medications that we use day in and day out do induce neurologic injury in animal models. And certainly, as I said, or as we all know, extrapolation of this data to humans is always challenging. It's always difficult to fully interpret, but I think the results of these really can't entirely be ignored, and that we have to think about how we can better care for our patients that are in this critical time period. And then finally, what are some of the criticisms? And hopefully I alluded to this a little bit, but certainly, as I mentioned before, the doses that are often used in these animal studies are supraclinical in terms of what we use on a daily basis. Oftentimes, though, these organisms need a higher amount of anesthesia, but nonetheless, that is one criticism, that they're just excessive dosing. The duration is often quite lengthy as well, and then oftentimes, with especially the older studies, there was a lack of surgical stimulus, and in that setting, the general anesthetics may have been a neuroprotective thing. So I'm going to hand it over to Megan to talk to you about translating some of this data into clinical studies. And unfortunately, this clip we wanted to show you was really great, but now...
Don't worry, it'll still be great. All right, can everyone hear me? Yes? Okay. So thank you, Chandra, for that great overview of the animal data. How does this animal data translate into human data? Are children who receive anesthesia going to have problems? How does neurotoxicity reveal itself in these children? Well, I do have this brief clip to show you. The sound may not come through, but I'll let you know what they say.
He likes to butt things with his head.
How proud you must be.
He likes to butt things with his head. How proud you must be. Did this child have an anesthetic? I don't know. But in all seriousness, we'll now talk about what some of the human studies show. Does anesthetic-induced CNS toxicity occur in children? Well, some data indicates that it may, but this is difficult to interpret from the human data. The idea of this has been around since the 1950s, when parents were administered a questionnaire after their children underwent anesthesia, and they found that these children did have some behavioral changes. In recent years, the interest in clinical outcomes after anesthesia has grown, and there have been many retrospective studies. I'm going to take the time to highlight some of the retrospective studies that are the most frequently cited, and the ones that your patients may have heard about and may ask you about. The first is this birth cohort out of Olmsted County, Minnesota. This is the Mayo Clinic studies that have been in the news around here recently. What they did was they did a study of association between anesthetic exposure before age 4 and the development of learning disabilities, which included problems with reading, written language, and math. This was a population-based retrospective birth cohort study of children born between 1976 and 1982 in Rochester, Minnesota. They had over 5,000 children in the cohort, and almost 600 of them underwent general anesthesia before the age of 4. What they found when they looked at the outcome of learning disabilities was that a single exposure to anesthesia was not associated with an increase in the susceptibility to learning disabilities. However, they found that multiple exposures to anesthesia or longer cumulative duration of anesthesia exposure did increase the risk of learning disabilities. And to look at that in a figure from the paper, this dotted line here is children who did not receive any general anesthesia. This middle line is children who received one general anesthetic. Over on the y-axis, we have learning disability diagnosis percentage. And this dark line, that's much higher percentage, is children that received multiple anesthesia exposures. So they did conclude that exposure to anesthesia was a significant risk factor for the later development of learning disabilities in children receiving multiple but not single anesthetics. And while there are limitations to birth cohort studies that I will address shortly, one limitation in this particular study is the use of learning disability as an outcome measure. Learning disabilities are not specific neuropsychological outcomes, and it's a little bit nonspecific the way they went about it in this study. They did use this birth cohort to look at if anesthesia has any effect in the causation of attention deficit hyperactivity disorder. Maybe it's just TV that causes that. But moving on to this actual study, it's the same birth cohort. Their objective was to study the association between exposure to procedures performed under general anesthesia before age 2 and the development of attention deficit hyperactivity disorder. Same cohort, and they looked at the incidence of ADHD in patients at age 19 years. What they found, again, is that children that had multiple exposures to anesthesia had an increased risk of ADHD. The figure from this paper is shown here. The orange line, again, is children with no anesthetics. The blue line is children that received one anesthetic. And this much steeper line with a much higher percentage of ADHD diagnosis is children that received multiple anesthetics. And so they concluded that children repeatedly exposed to procedures requiring general anesthesia before the age of 2 are at an increased risk for development of ADHD, even after adjusting for comorbidities. So the limitations in both of these studies that I've just mentioned are limitations because it's a retrospective study and it's a birth cohort study. One thing that's important to note is that you really can't distinguish between the anesthesia effects and the stress response to surgical stimuli. What came first, the chicken or the egg? Also, children undergoing repeat procedures may have a higher burden of illness. Maybe the reason that these children are having multiple procedures is because they're sicker, and maybe that's the reason that they're having an increased incidence of learning disabilities and ADHD. We don't know. Also, these anesthetics would have been conducted in the late 70s and early 80s, and they would have consisted mostly of halothane and nitrous oxide. So they may not be generalizable to today's anesthetic regimen. We don't have halothane at this hospital. It's not clinically used in this country anymore. We do use nitrous oxide, but we don't use it quite as frequently as it was used back in the time period that these children received their anesthetics. So can we generalize this to our patients today? We don't know. The optimal ages chosen to study the effects of anesthesia are unclear, as Dr. Castro mentioned. And then there are specific limitations to this particular cohort from Rochester, Minnesota. Rochester, Minnesota is not the most ethnically diverse place in the country. So can we generalize this to the general U.S. population? I don't know. Also, immigration from the birth cohort might bias results. A child who is sicker, their family may tend to stay in Rochester for their medical care instead of immigrating to somewhere else in the country and being lost to the cohort. Finally, and I think this is a really important question, is are learning disabilities and ADHD relevant outcome measures when we're looking at these things? We just don't know. So I'm going to talk a little bit about some more retrospective studies that look at different things. This is a birth cohort out of New York, this study by DiMaggio and colleagues. The purpose of this is to assess the association between surgery for hernia repair and risk of behavioral and developmental disorders in young children. They looked at children that were in the New York Medicaid program born between 1999 and 2001. They had 380 children who underwent inguinal hernia repair during the first 3 years of life. Over 5,000 age-matched children with no history of hernia repair before age 3 were the comparison group. Now, I will mention, these children could have had anesthesia, just not a hernia repair. Oh my goodness. Let's get out of that. Technical difficulties. Okay, so what did they find in this study? Statistically significant association between hernia repair under age 3 years and an increased risk of behavioral developmental disorders existed in this population. 4% of patients who had hernia repair ended up having some sort of behavioral developmental disorder, and this was characterized by ICD-9 codes, so that's how they determined if these patients had these diagnoses. 1.2% of the comparison group had this, and the authors stated that this could not be explained by confounding factors such as low birth weight, comorbidity, demographics. Again, some of the limitations are the same in this birth cohort study. By looking at these records, it was not possible for the authors to establish the type, dose, or route of anesthesia. We're still unclear what's an effective anesthesia and what's an effective surgery. And this Medicaid population that was used it differs from the general population. It's ethnic components, socioeconomic status, and then there is an increased incidence of mental illness in this population. So looking at behavioral and developmental disorders, this may not be the best population to generalize from. The same birth cohort was used for a sibling study. They had an exposed group and an unexposed group of 10,000 children. The exposed group had surgery under the age of 3, any surgery. The unexposed group had no surgical procedures under the age of 3. What they found that when they looked at these two groups was that there was an increased risk of later diagnosis of developmental and behavioral disorders in the exposed group. Again, they're looking at ICD-9 codes to find this. And this is when they look at exposed versus unexposed, not when they look at siblings. When they look at siblings and when they look at discordant pairs of siblings, there really is no difference. So if you look at this, I've listed kind of all the results, but this is what I want to highlight, this 20 discordant pairs, so not a high number. They basically found that in 9 pairs, the one exposed to anesthesia had the diagnosis, the unexposed didn't. In 11 pairs, the unexposed is the one that had the diagnosis, and the exposed didn't. So what conclusions can you draw from that? Not a whole lot. So that's something to keep in mind. Another study that looked at a twin registry in the Netherlands had sort of similar results. They looked at exposure to anesthesia before age 3 and educational achievements at age 12. And they found when they looked at all of the children in their birth cohort, exposure before age 3 reduced or increased cognitive problems. So they did see an association there. But when they looked at discordant twins where one twin had anesthesia and the other twin did not, they found no difference. The way that they did this was they looked at data collected from parents and from teachers at various ages of these twins. The twins were born between 86 and 95, and they removed twins that were born before 32 weeks gestational age. But to put these results in another way of saying it, the unexposed co-twin from the discordant pairs did not differ from the exposed co-twin. And I'll quote the article. They say, a child who receives anesthesia is no more likely than his genetic duplicate to have lower achievement on a standardized test for educational attainment or worse cognitive problems or inattention as rated by their teachers. So there's that. Another study out of the University of Iowa, go Hawks, looked at effects on academic performance. They had 58 infants who underwent one of 3 operations. The operations that they chose for this are operations that are normally performed on generally healthy children. So they looked at kids that had a circumcision under general anesthesia, an inguinal hernia repair with orchiopexy under general anesthesia, and a pyloromyotomy. So those were the 3 operations. And they looked at the Iowa Test of Basic Skills as a measure of academic achievement. When they looked at mean standardized achievement test scores, the mean of this group did not differ from normal. So they were about average. However, they did have an overrepresentation of very low test scores below the 5th percentage. And they did see an association between test scores and the duration of anesthesia. What they concluded, which is what I think all of you are concluding right now, is that further investigations are needed. We just don't really know. I'll leave you with one more retrospective study before we move on to some of the current things that are being done. And this is another birth cohort looking at hernia repair in infancy. Why does this keep happening? Don't worry, technical difficulties. This is a Danish birth cohort of kids born between 86 and 1990. There were over 2,000 children who had a inguinal hernia repair in infancy. And they compared these to an age-matched, non-exposed population sample. And what they found, just to briefly summarize, was that a single relatively brief anesthetic exposure did not reduce academic performance at age 15 to 16. So, even if your child had an inguinal hernia repair in infancy, they may be interested in this literature. I'm going to turn it back over to Chandra.
So I just want to quickly kind of wrap some of these things up here and talk to you a little bit about what sort of work is underway today and what can you look forward to in the future in terms of more progressive information and that sort of thing. So as I mentioned earlier, the FDA has taken a great interest in this issue, and in 2008 they actually merged with the International Anesthesia Research Society to form a partnership which has been called SmartTABS. And that SmartTABS website is an excellent resource if you want to go to see kind of what current information is out there, what studies are underway, what preclinical studies have been done, the recent consensus statement, which we'll talk about. So it's a nice resource for all practitioners, I think, to use. And basically with this partnership, they then established a scientific advisory board, went through some fundraising efforts, and have at this point at least, given 2 significant grants to 2 different researchers, one at Columbia University and one, this Dr. Block that Megan just cited this inguinal hernia study, or I'm sorry, the other study in. So currently we have a couple of nice grants out there that are looking at various issues, and basically they forged together to create a long-term alliance to help understand the human implications of this problem. Just to let you know about a couple of studies that are underway that are more prospective in nature, which will hopefully give us some more clear answers. There are 2 to really mention at this point. The first is called the GAS, the General Anesthesia Study. This is an international randomized study that's underway. This is primarily being led by Boston Children's Hospital as well as the Royal Children's Hospital in Australia. And essentially what they are doing is recruiting 600 infants that are under the age of 60 weeks gestation. So a lot of them, I have to say, at least the ones that I've known about, have been potentially ex-preemies or slightly premature infants that are under 60 weeks that are coming in for an inguinal hernia repair. And they've been randomized prospectively to either receive a more typical general sevoflurane anesthetic versus an awake spinal anesthetic with plus minus a caudal as well. So what they're aiming to do is a 5-year follow-up on these patients where they do extensive neuropsychological testing and that sort of thing at ages 2 and 5 and potentially be able to give us a little more causation versus just simply suggestion or association. And then finally, I mentioned the PANDA study. And this is a study that is underway by, primarily led by researchers at Columbia University. It is a multi-institutional study that is ambidirectional in nature. So effectively, they have retrospectively recruited this group and are prospectively looking at them and testing them. It's a sibling matched cohort study. So they're looking at 500 sibling pairs that are discordant for their exposure. And these are patients that have had inguinal hernia repairs under 36 months and that have been identified or classified as ASA 1 or 2 status. So generally, they're more healthy patients. They will undergo then extensive neuropsychological testing at various time points between the ages of 8 and 15. Hopefully, the goal with this study is by using these siblings that are discordant that they will try and eliminate some of the environmental and genetic confounders that are at play. The other kind of goal of this as well is that because they are healthier patients, hopefully this is a little more generalizable to the population of patients that we are anesthetizing more routinely in the United States. So I'm going to turn it back to Megan to wrap up here and share with you some of the main points of the consensus statement that came out in December, and then get back to our case scenario and final points.
So in September, a group of experts from around the country participated in the Smart Talk conference to address the current state of affairs of this issue and develop a consensus statement. I've listed the website up there, which has the full consensus statement and a lot of the information about Smart Tots, if you're interested in going there. And then what I have included on this slide is just sort of the meat of the consensus statement and what we should do as healthcare providers. So we should discuss with parents and other caretakers the risks and benefits of procedures requiring anesthetics or sedatives, as well as the known health risks of not treating these conditions. We should stay informed of new developments in this area and recognize that current anesthetics and sedatives are necessary for infants and children who require surgery or other painful and stressful procedures. I'm going to take a moment to go back to Molly, our initial patient that we mentioned at the beginning of this talk. To remind you, she's an 8-month-old ex-32-week preemie with delayed milestones and suspected CP who presented to the sedation unit for a brain MRI. Well, what are some of the considerations that I'm thinking about when I take care of this patient and that primary care providers should be thinking about when they order this scan? A brain MRI in general takes about 45 minutes. So that's 45 minutes that the patient needs to lie still. So an 8-month-old needs anesthesia. We need to be thinking about what is the purpose of this study when we order it. What is this going to show us? Is this potentially going to result in an intervention for this patient or change her care? We also need to consider, could this data be obtained from a CT without general anesthesia, a CT that's a minute or less? Probably not, but some studies, some patients, a CT is maybe a better option, but we have to balance the risks of radiation versus the risks of potential neuroapoptosis from general anesthesia. The other thing that we need to think about is the scan needed now or could it wait? Is this something that Molly needs to have right now where she's about 6 months corrected gestational age, or is it something that could wait a year? Just things to kind of food for thought when you're thinking about these scans. We all should be thinking how we can provide the best anesthesia and preoperative management for these children to reduce any potential neurobehavioral risks. And that goes for surgeons, anesthesiologists, pediatricians, any member of the patient's care team needs to be thinking about these things because we just don't know. We've all made a commitment to do no harm. So given the current body of information that we've briefly introduced to you, what should we or could we be doing differently? As I said, we always need to be thinking about, does this child require a procedure or imaging study? Is this something that needs to be done? We should consider the dose and duration and mixture of agents that we use. And that's something that Dr. Castro and I are thinking about constantly, and anyone who provides pediatric anesthesia care is thinking about. We're not going to use a much higher dose of volatile anesthetic that we need. We're going to try to combine things and use potentially less neurotoxic agents when we can. We should consider the method of repair. If there are two different surgeries and one could take many, many hours and one could be much briefer exposure to anesthesia, we're going to have to talk with our surgeons and discuss if it's better for the patient to have the longer or shorter procedure in the light of potential neurotoxic effects of anesthesia. We should increase our use of regional anesthesia, and that's something that we've really been doing here at AMPLATS in the past year. When a patient has a regional anesthetic, even if they still have a general anesthetic on top of that in the operating room, we're able to use less volatile agent. We're able to use less of some of the other drugs that we use. And so we've been trying to increase that use in the interest of taking better care of our patients. We should probably consider increased use of dexmedetomidine or other agents that potentially could be neuroprotective when appropriate. And we have our eye on the literature. There are many things that may play a role in the future, things like estradiol, melatonin, xenon, L-carnitine, lithium, hypothermia, and of course, narcotics. Narcotics are good. But we're going to be looking at these things and consider how our practice needs to change in the future. So, just in case you were thinking that this neurotoxicity stuff may put the two of us out of a job, we must mention the potential benefits of anesthesia and acknowledge that it's a necessary piece of the care of many children. Infants undergoing inadequate anesthesia have been shown to have poor outcomes. Surgery and pain result in harmful metabolic, immunologic, and humoral responses, and anesthesia and analgesia may reduce those responses. It's ethically unacceptable to subject infants to invasive procedures without the benefits of anesthesia. So we think we will still have a job, but anesthesiologists must be open to the possibility of changes in practice. A few take-home points to leave you with is that evidence for anesthesia-induced neurologic injury is compelling in animal models. However, the available clinical studies are retrospective and inconclusive. Prospective studies are underway that will hopefully help to further sort out this complex issue. We are happy to take questions. We're happy to take questions today and to take questions at any time. If you have any questions about this topic or any topics relating to pediatric anesthesia, we've really enjoyed being part of the AMPLATS team this past year and taking care of the children here. And please just feel free to approach us and talk to us at any time. These are our kids. Thank you.
Of the surgery itself. Are there any studies looking at anesthesia performed solely for imaging, hopefully not brain imaging, rather than for surgery?
I personally am not aware of any that are underway for that reason, but it's an interesting question because obviously there's not a stimulus there. And certainly, there's, aside from imaging, I can think of a lot of, there are a few things that we do pretty routinely for patients that aren't that stimulating, whether it's a PICC line, things like that. Yeah, there's a slight stimulus, but it's not that significant. I don't know of anything. Do either of our anesthesia colleagues here know of anything? No? Yeah.
So with some of these studies that seem there's a marginal change or a little bit of skewing of the distributions, you wonder if you're really just culling out a susceptible population because of some metabolism, polymorphism. Are these drugs, are there known different pathways that vary across, in predictable ways across people, depending on metabolism, polymorphism?
genetic.
Yeah, genetic polymorphism.
Yeah. Of the more commonly used ones, I mean, I can't think of anything specific about that right off the top of my head. There's certainly that consideration with some of the narcotics, but in terms of other general anesthetics, nothing specific is coming to mind.
Yeah.
Do you know of anything, Dr. Prelip or Balani?
Genetic polymorphism is now taking a big role in anesthesia.
Right.
So I think that's something that we can address in the future, but nothing with these studies. The other thing is, if somebody is interested on our campus here, you can retrospectively look at two cohorts. One is the Dr. Foka cohort, and the other one is Dr. Ani Lemon cohort, because there are differences in the duration of surgery for both. And we can see the outcomes. But if somebody is interested earlier, nice.
Yes.
I think it's important to consider when you have population-based studies, even though the type of anesthesia given at the time, especially in the Olmsted County studies, those should be taken seriously. We have animal models that seem to be susceptible to some type of bad neurologic outcome. And if we take the types of kids that we see in this institution, and we say, well, we have the kids who seem to be developing normally, that they have a procedure that really is not necessarily central nervous system based. This institution anesthetizes a lot of kids who have neurologic disease. And those kids, I think, are particularly susceptible based on what I see in my group as a child neuropsychologist. I think that we need to take very seriously when we have kids that are anesthetized multiple times because they're young and they've had their brain tumors and they're getting annual MRIs. And we need to be very careful in children who have adrenoleukodystrophy or some type of MPS, lysosomal disease disorder. We are asked to see these kids as part of research studies in which our neuropsychological outcomes are considered important, but we continuously wonder to what degree are we also looking at the long-term and late effects of sedation.
I think that's a great point. So.
Just a follow-up on that. I'm not a peds anesthesiologist, but I was part of the FDA consensus panel, and there were about 40 practitioners of all disciplines, including pediatric dentists, who give a lot of anesthesia to children. And the response to this is just as wide a spectrum as the data itself, but there's no question when you talk to clinicians, pediatric surgeons, and some organizations, this issue has profoundly impacted the way they're caring for children and the way they're ordering imaging studies or timing out elective surgery like a umbilical hernia. Can you just teach the mom what to look for a couple years and prepare it at 3 years of age instead of 3 or 6 months of age? So the response to this is as profoundly diverse as this conflicting data represents as well.
Yes.
I'm sorry, I wasn't here for the animal studies, but from the animal studies, can you rank? It seems like you are ranking your drugs by neurotoxicity. How good are those other drugs? So they're really growing.
There's a few primate that are primarily with ketamine. There's some piglet studies as well, but then primarily rodent studies. I wouldn't say, I guess at this point, that we're ranking the way we use our drugs because, unfortunately, I think you might have missed the initial slide where I talked about what drugs have been implicated, and unfortunately, they're the majority of the things that we use. So all induction drugs. The only things that are really out of this classification are the opioids and dexmedetomidine. It's kind of interesting. I mean, who knows? Maybe we'll see an increased use of dexmedetomidine. I think it's a wonderful drug for lots of reasons. So it'll be interesting to see how it all plays out. But it's the things that aren't known, for example. So you might give propofol as an induction dose to put someone to sleep, but is that harmful to give that just an induction dose, versus, I think the things that I feel more concerned about today, knowing that this data is not perfect, is that I think we, have a commitment to try and limit what we can. So we know, like, for example, that at least the animal studies have certainly pointed out that it looks like the apoptosis response is dose-dependent and duration-dependent. So I think we have an obligation to try and limit the dose if possible, and also to limit the duration if it makes sense. So, when we combine various things in the operating room, a lot of times we can sort of reduce some of those factors if we are combining other techniques like we've mentioned today, maybe doing more regional anesthesia and that sort of thing.
And regional anesthesia does not seem to have these effects on the anesthetic.
Alone, we don't think so, but prospectively being looked at. It's not entirely clear, but we don't think it does.
I'm not familiar with what's
Sure.
Yeah, it's an alpha-2 agonist, much like clonidine, that has sedative properties. It has a little bit of analgesic properties, and we use it mostly as an adjunct. It can be used to treat emergent delirium. It can be used for sedation. In my fellowship, we actually did the majority of our MRIs under dexmedetomidine, unless there was a contraindication. Being that it is an alpha-2 agonist, it can produce bradycardia. It does produce bradycardia. So you have to be slightly tolerant of bradycardia and ensure that you have adequate blood pressure and not worry too much about the heart rate, which is hard for some of us when we take care of children. But it's, I think that right now at Amplats, we're mostly using it as an adjunct to the rest of our anesthetic. We're not using it alone in children. It doesn't provide the same depth of anesthesia that, say, a propofol infusion would provide. Children still react to stimuli while they're under dexmedetomidine. So it's not as satisfactory to many people to do a procedure on a child that is just having dexmedetomidine. Anything to add? Dr. Thompson. I haven't seen any reports of magnesium used sort of as an adjunct. As anyone who's been preeclamptic knows, it feels very icky. So it may feel very icky to patients waking up, but one thing that we didn't mention that relates to that question is that there have been studies that look at mothers who receive regional anesthesia during childbirth versus general anesthesia during childbirth, and they have seen no changes in some of these neurodevelopmental outcomes in babies in those two groups. Yes?
Is there any transporter studies? Because all this NMDA and GABA, some related studies that you had shown. Like, is there any transporter related studies? Because that would have entire transporters have their study methods. And in terms of all these anesthetics, is there any blood-brain barrier studies?
I don't really know of either of those specifically. I think, I've certainly seen mention of are there potential targets for transporter studies, but I personally have not come across anything like that at this point. So, sorry. Okay.
Thank you, everyone.
Thanks so much. Really? Well, hey, there you go.
Great job, man.
Thank you. Thanks for being here. It's nice to have some senior people to say, like, hey, can you weigh in on this with us? Newbies here.
I like this team.
The back and forth. You're in this with me, whether you like it or not.
First teamwork is just one thing if you want to eliminate that interference, just turn off the wireless.
Yeah, one or the other.
Okay. Yeah, I think she was using it upstairs. And then,
But you use the wireless for that video, right?
Yeah, thanks for asking
well,
us to do it.
we had that loaded, but
Thank you very much.
thanks, Ashley. Thanks.
Good job.
Bye, guys. Thanks so much.
Yep. Thanks. Good job, man.
Thank you.
It was very nice.
Thank you very much.
Thanks for coming.
Yeah, and Is there any studies on...
The scientists will help us with future studies.
Okay.
All right, good deal.
Well, Kumar, you should bring him to our research meeting then. Okay.
Is there any serum-based studies like metabolomics, like, for example, all this genetics and, it's population dependent, because if you see children in Asian countries, they are more prone to all sorts of, influenza,
things,
everything.
yeah.
Even the genetic polymorphisms were different. So, do you think there are any other studies which is related to the breakaway products in the serum that would really help these patients?
That is very interesting to think about. I don't know.
Yeah.
I mean, I don't know enough about that.
I don't either. Is that your particular area of interest?
Yeah.
Yeah.
Because I think the children in United States, they are more, not stress related basically, like, whereas those, because it's better to compare these two groups. There is one thing that I thought of. You have a research laboratory here?
Do we have what?
Research laboratory?
We don't have one in this hospital, but like Dr. Balani, you might know they have a lab and stuff over on the East Bank campus. A lot of what we're kind of doing over here right now is more of clinical nature, but I think we're
But there is
sort
a
of
possibility
open.
of collaboration, am I right?
Oh yeah, for sure. We are on, I was being serious. We're having a pediatric research meeting on the 23rd, so next week on Wednesday from 5 to 8 here. And
I'll speak to Belani.
yeah, ask him
I'll try
about
to
it.
be here.
We'd be happy to collaborate. So.
Yeah, there are a lot of ideas that erupt.
Well,
out
I just had a
actually.
couple things pop into my head during our discussion. I was like,